Hello, my name is Michael Eller. I'm a third-year medical student at the University of Nebraska Medical Center, and this is my clinical vignette presentation named Double Trouble with Trimethoprim-Sulfamethoxazole. I would like to thank Dr. Fagerlin, Simmons, and Langenhan for their help with this presentation. Drug-induced immune thrombocytopenia purpura and aseptic meningitis are rare and potentially life-threatening side effects of trimethoprim-sulfamethoxazole use. This case demonstrates a unique occurrence of both these rare adverse effects and highlights the importance of a medication reconciliation. Drug-induced ITP typically presents as an isolated thrombocytopenia and can potentially lead to life-threatening bleeding. Common sources of drug-induced ITP include heparin, quinidine, and TMP-SMX. There are three proposed mechanisms by which drugs can cause ITP. The literature proposes that TMP-SMX causes ITP via an immune-mediated mechanism by creating antibodies against platelets. There is currently no lab test available to measure the presence of these antibodies, and as such, make it a diagnosis of exclusion. Another rare side effect of TMP-SMX use is aseptic meningitis. Aseptic meningitis is defined as a condition in which there is clinical and laboratory evidence of meningeal inflammation with negative bacterial cultures. Medications linked to this condition include NSAIDs and antibiotics like TMP-SMX. Drug-induced aseptic meningitis presents similarly to other sources of meningitis, and CSF analysis typically shows a neutrophil-predominated pleocytosis with normal to low glucose and increased proteins. This is also considered a diagnosis of exclusion, and other causes such as viral or fungal meningitis must be thoroughly worked up. Now for the case description. A 27-year-old man presented to the emergency department with a 3-day history of headache, neck stiffness, night sweats, fever, and rash. The symptoms began with a severe headache that was exacerbated by going from sitting to standing. The patient reports that his neck stiffness was worse with rotation, and the patient noticed a rash on his chest and arms after going on a walk outside, which brought him to the ED. On arrival, the patient had the vitals as seen. Of note, he had a temperature of 38.3 degrees Celsius. On physical exam, the patient had of note petechiae of his oral mucosa, small conjunctival hemorrhages, and a petechial rash on his upper chest and extremities. Meningitis was suspected and a lumbar puncture was planned. Prior to LP, the patient had some blood work done that shockingly showed a CBC with a platelet count of 0. Other lab work showed a slight elevation in his creatinine and LFTs. The LP was canceled and blood cultures were drawn. He was admitted to the intensive care unit and started on empiric treatment for meningitis with vancomycin, ceftriaxone, and dexamethasone. On further workup, imaging showed no abnormalities. Investigation of the isolated thrombocytopenia showed no evidence of hemolysis. Autoimmune disease evaluation with ANA was negative, and an extensive infectious disease workup was also negative, including those seen on the screen. Medication reconciliation revealed that 10 days prior to admission, the patient was prescribed a 2-week course of TMP-SMX for a suspected urinary tract infection. TMP-SMX was discontinued, and the patient began treatment for drug-induced ITP and aseptic meningitis. He received 1 unit of platelets, 2 doses of IVIG, and prednisone 70 milligrams for 2 weeks. Meningitis symptoms improved, fevers resolved, and platelet count rose. It was 73 at discharge and 367 at hospital follow-up 9 days later. While severe adverse reactions are relatively rare with commonly prescribed medications such as TMP-SMX, this case highlights that the general internist must include adverse reactions on their differential, and that a thorough medication reconciliation may lead to a diagnosis. This case is unique in that the patient appears to have presented with both a drug-induced ITP and suspected aseptic meningitis, 2 rare but serious complications of TMP-SMX. TMP-SMX is a frequently used antibiotic that is useful in a variety of infections. The most common adverse effects are mild gastrointestinal and dermatologic reactions. However, there are well-documented associations between TMP SMX, in both ITP and aseptic meningitis. Systematic reviews found that TMP-SMX is the third most reported cause of drug-induced ITP and the most reported antibiotic cause of aseptic meningitis. Using this criteria from the literature, we can grade the likelihood of TMP-SMX being the cause of the thrombocytopenia seen in this patient. First, the TMP-SMX was started about 10 days prior to admission, and the thrombocytopenia resolved after its discontinuation. Second, the TMP-SMX was the only medication being used by this patient prior to admission. Lastly, all other causes were excluded. The fourth criteria of rechallenging the patient was not met for obvious ethical reasons. As you can see, this makes TMP-SMX the most probable cause of ITP in this patient. Due to the extreme thrombocytopenia found on admission, an LP was unable to be performed to allow for CSF analysis. Without these results, it's hard to make a definitive diagnosis of aseptic meningitis. However, the patient's presenting symptoms are much more consistent with those of aseptic meningitis than ITP alone. There was also complete resolution of these symptoms with the discontinuation of the TMP-SMX. Once again, for the general internist, this case emphasizes the importance of maintaining a broad differential, which should include drug-induced adverse effects. Early identification and withdrawal of the offending agent can lead to rapid recovery. I want to thank the ACP of Nebraska for allowing me to present this extremely interesting and informative case. Thank you.